Okay, Assalamu alaikum and good evening to all of you. This is the conceptual basis of urology course in which we have a 1-hour session, first and third Saturday of each month, interactive session with experts around the world to talk about some of the interesting contemporary issues in prostate. And as you remember, we have done MRI of the prostate in the last session. And this time on, we are going to continue with our previous session. We will be discussing interesting cases and MRI scan of those cases. And I'm really very happy to note that we have Dr. Basit Salam, who's a radiologist working as a consultant in Sultan Qaboos University. He's going to be with us as well, in the last session. So, as you know, that prostate cancer has variable biological potential. It is indolent disease in some, and it's extremely aggressive disease in others. And we have only clinical staging, PSA value, the Gleason grade, as some of the three major parameters on which the biological potential is defined. And we say that this is clinically significant cancer versus this is not clinically significant cancer. MRI is making big inroads, and MRI will ultimately become a very important source in identifying prostate cancer which are aggressive and which are clinically significant and require treatment. So it is at the moment not included in most guidelines, but I'm sure it will sooner or later. So it helps us in staging the disease, local regional disease staging for nodal disease as well as the original prostate cancer. It also provides additional information about clinically significant prostate cancer. And if you recall last time when we were discussing MRI scan, we talk about PIRAD grading. And PIRAD grading is the one that helps us in knowing what is 4 and 5 cancers. And obviously these 5 cancers are aggressive cancers. Besides this, it also helps us in making decision for a biopsy and surgery. And these decisions are important not only in characterization of the lesion, localization of the lesion, and sometimes direct our biopsies by what is called a fusion biopsy using MRI and transrectal ultrasound. So if you remember the anatomy, just a little recall that this is seminal vesicles draining into through the ejaculatory duct into the prostatic urethra, and the zone of the prostate which is around the prostatic urethra is called the transition zone, and this is the place where the majority of your BPH develops. Central zone is around the ejaculatory duct. It's typically a small area. Peripheral zone is the biggest zone of the prostate, and it is in the periphery, and this is where about 75% of the prostate cancer develop. Anterior fibromuscular stroma is a small area which has little clinical significance. It is the prostate is then divided into anterior and posterior, and then 3 zones: the base, mid zone, and the apex. So each part is then subdivided into 12 sectors. And we'll show these sectors also on the MR scan, and Dr. Basit will tell you what are these different sectors in the various parts of the prostate, like in base, mid zone, and apex. And since prostate's anatomy is such that it is not geographic, it is not a geometrical structure, all the zones and sectors are represented in various proportion in the different zones of the prostate. So what we do, the MRI prostate protocol is pretty standardized now. You need to have a T2 weighted coronal images, and these are important to understand the zonal anatomy of the prostate. And we know that the zonal anatomy of the prostate is really extremely important in understanding the various pathology. So as you can see, this is a T2 weighted image. This is the surgical capsule that most of our colleagues know who do TURP that this is the point until which you need to resect to clear up the BPH. This is the peripheral zone, which is T2 hypo intense, and it is showing capsule, but this is not a real capsule. It is just a condensation of tissue around the fascia. So besides this, you need to have high B-value diffusion weighted images, and then the ADC mapping. So T2 weighted, the DWI with ADC map is important. Then you also have T1 weighted images, and these are taken pre and post contrast if you're doing dynamic contrast enhanced MRI scan. And these are important to particularly look for hemorrhage. Then you have a global picture of one orthogonal reconstruction, which is either coronal or sagittal or both, in which you go from aortic bifurcation down up to the apex of the prostate to see nodal disease as well. So if you look at this picture, again, very clearly, it is showing the various sequences and what exactly that they show. So this is T2 weighted images. You can see a large BPH zone or transition zone, seminal vesicles here, the bladder on the top, rectum here. This is your peripheral zone. And then you also have one coronal reconstructed image with T2 weighted image, the DWI, the diffusion weighted images, and the ADC map that develops with it. And all these are complementary to each other. T1 weighted image, as I've said, and in T1, you can also see some zonal anatomy. The hemorrhages are identified in the prostate. You can have post-contrast, pre-contrast and images as well using T1 weighted sequence. And then you have one global picture of the lower abdomen, starting from aortic bifurcation down up to the apex of the prostate and urethra to see the nodal distribution and the nodal disease. So this is just a bit recap from what we have discussed last time, and I'm going to now move on to our presentation and carry on with the presentation that we have to stop last time because of short time. So just give me a second. Let me just upload the other presentation.
In this talk, I want to give you guys a
Okay, so is the slide visible to all?
Not yet, sir.
Not yet? Okay. Is it visible now?
Yes, sir, now.
Okay. Dr. Basit.
Yes, Assalamu alaikum. So we can see the three images. The top image on the screen is a T2 weighted sequence. And here, if we see on the left side, which is being marked by the yellow arrow, you can see if we compare it with the contralateral side, there is a signal intensity difference. This area is appearing hypo-intense. And if we carefully look at the margins of these lesions are irregular And of course, this is in the peripheral zone. So we are going to complement the T2 finding with the DWI and ADC mapping. So if we look this on the DWI, which is the bottom right image on the screen, showing hyper intense or bright signals as compared to the other prostatic parenchyma. And subsequently on ADC, this lesion, this area or this lesion is appearing markedly hypo-intense, making this lesion highly suspicious. And of course, the pirate categorization for, as we discussed in the last meeting, the size differentiates pirate 4 from pirate 5, which is 15 millimeter or more is pirate 5, or if less than 15 millimeters, then it is pirate 4. So this is a lesion which is highly suspicious. And if we carefully look the capsule that Dr. Hamad very well explained while explaining the anatomy, if you see on the right side of the top image, you can see a black line. This black line, if we see on the area where the lesion is, can you just show this black line, which is at the bottom outside the peripheral zone? Which yes, this line is indistinct on the side which is marked by the yellow arrow. So there is a strong suspicion of extra prostatic extension based on this indistinct appearance of the capsule. And can we move on to the next slide, please? So I think this lesion was biopsied, and it was the measurement of this lesion was 17 millimeter, making it a pirate 5 lesion, and biopsy turned out to be a prostatic cancer lesion, and the biopsy confirmed extra prostatic extension as well. And the Gleason score was 4+3, and like I said, we need to see these peripheral lesions. We will also subsequently discuss in the subsequent cases that this lesion was appearing hypo-intense on T2 and markedly hypo-intense on ADC mapping, plus the margins were indistinct or ill-defined, like I showed. So can we move to the next slide, please? So again, another example, like we saw the last case, in which here we see that there is a hypo-intense lesion in the peripheral zone on the left side, which is being shown by the arrow. And if you see that this is giving you well-defined distinct margins, and we subsequently look at the ADC mapping and the diffusion. So on diffusion, it is not behaving differently versus the rest of the peripheral zone, while on ADC, it is slightly hypo-intense, but has well-defined margins, unlike the lesion that we see. So these kind of lesions, which are wedge-shaped or very well circumscribed with well-defined margins, are usually secondary to prostatitis, and the biopsy confirmed this lesion to be prostatitis. And if we look at the contralateral on the next image, which is on the left side of the screen, we see another area on the contralateral side, which is again appearing slightly iso to hypo-intense on T2, as shown on the arrow. But if we see the diffusion restriction, there is hypo-intensity of this lesion. This lesion was characterized as pirate category 3 because of these intermediate signal intensity of this lesion. But this lesion is pirate 3 because the margins are not very distinct, and we have to now follow the post-contrast sequences for further characterizing this lesion. If available, sometimes because of the creatine clearance issue, we do not give contrast. So this lesion will be classified as category 3 lesion because of indexed margins and some element of diffusion restrictions. If there is no enhancement, then we will put this lesion as category 2 lesion.
So, Dr.
Next.
Basit, if I have understood correctly, the lesions which have a particular shape, like this is a wedge shape, it has clear margins. It is shown on the ADC map, but not on the diffusion weighted images. Then it is less likely to be a carcinoma. It's more likely to be a inflammatory lesion or prostatitis, right?
Yes, agreed. Because the pyrite is defined like this based on their appearance, on their characteristic. If there is a real cancer, it should be reproducible on all these sequences which the pyrite recommend them to see. Of course, we use different sequence for the transitional zone versus the peripheral zone. So for peripheral zone, it is the T2 and then the ADC and diffusion. But we start with the ADC and diffusion with for peripheral zone and look complement them with T2 and post contrast sequence. For transitional zone, we rely mostly on T2 weighted images, and because the transitional zone, the enhancement is most of the time confusing. So then we have to respect the restriction and the diffusion and ADC mapping.
Right, thanks. So this is exactly what is just described by Dr. Basit, the two lesions that we have seen and why they are cancers in the previous one and why it is not a cancer in the other one. So this is extremely important because in majority of these cases, clinically relevant important point is that you can avoid a biopsy even if you have a raised PSA and your pyrite grading on your MRI scan is 3 rather than 4 or 5. So the chances that even if it is a malignancy, it is likely to be a clinically insignificant malignancy, more likely that it is likely to be a inflammatory thing rather than a cancer. So these are some of the characteristics about lesions which are suspicious lesion in the peripheral zone. And on T2 weighted images, they are ill-defined and hypointense. Lesions which are less suspicious are bilateral, symmetrical, diffusely distributed signal changes, wedge-shaped, as we have just shown and Dr. Basit explained, sharply demarcated on. So these are some of the characteristics that you need to remember when you are reading your MRI scan and distinguishing lesion 3 from lesion 4 and 5. We know that lesion 4 and 5 are aggressive cancers and the likelihood of cancer is high in these lesions. So another case, Dr. Basit. You're muted, Basit.
Yes, sorry. Thank you for reminding. So here we have the top image is the T2 weighted sequence, and the bottom two are the diffusion weighted sequence on the right side and the ADC mapping on the left side. So we see a lesion which is appearing hypo-intense on T2 weighted sequence, and it is shown by the yellow arrow. And if we see that this lesion does not have very well circumscribed appearance, and though this is homogeneous and hypo-intense, and if we follow on subsequent diffusion weighted images. So on ADC, it is appearing markedly hypointense. This marked hypointensity makes lesion very, very suspicious. So this lesion again is highly suspicious. And if we closely look at the margins, so the margins are irregular, non-circumscribed, and kind of speculated. And this kind of appearance is on MR referred to as when we use the charcoal pencil and we erase it, and it appears if it is not properly erased. So this smudgy appearance is called erased charcoal kind of appearance, which is defined for these kind of lesions. But on ADC, this markedly hypointense appearance of this lesion, and of course diffusion restrictions making this lesion highly suspicious. And next slide, and I think this also turned out to be cancer.
Yes, it did turn out to be a cancer. It was 3+4 Gleason grade cancer on biopsy.
Yes, and let me give you one more example on this previous. If you look at the peripheral zone below the yellow arrow, you again see a bed-shaped areas which is slightly low in signal intensity and no significant restriction. So these kind of appearance which are well-defined versus ill-defined lesions are usually of benign etiology, non-circumscribed or ill-defined lesions are suspicious, which have marked hypointense signal on either T2 or ADC.
Yeah.
Yes. Next
So
slide.
now you can see that we have talked about peripheral zone lesions and their characteristics which make them suspicious of cancer. And now we have talked about transition zone disease, which are suspicious because we know that about 1/4 of all cancers can be in the transition zone as well. So about 25% of cancers are in the transition zone. So the transition zone, the images as described, there was a lesion in the right anterior part of the transition zone. And just to recap, the transition zone has anterior and posterior part, whereas the peripheral zone has anterior, posterior lateral, and posterior medial. So right anterior, right posterior lateral, and right posterior medial. And this is how you describe the location of your lesion so that there is no misunderstanding. Whereas the transition zone only has anterior and posterior. Okay. And I think it is all described by Dr. Basit. And as I've told you that the biopsy of this lesion showed a 3+4 Gleason prostate cancer. It was categorized as a pyrate 4 lesion. Right, so this is another interesting case. Basit, would you like to describe this?
Yes. So again, we have the three important sequence, T2, DWI, and ADC. And on T2, if we see the anterior part of the prostate, we see a ill-defined or non-circumscribed hypointense lesion, which is anteriorly in the anterior fibromuscular stroma region, which is again showing diffusion restriction, and the size of this lesion is definitely exceeding 15 millimeter, making it category 5 lesion. And again, if we look carefully on ADC mapping, the bottom left image, you can see marked hypointensity of this lesion. And on DWI, this is appearing bright or hyperintense. So these features make it highly suspicious to be characterized as a pyrate category 5 lesion. We can see that the capsule appears to be intact on these provided images. So this is a category 5 lesion. Yes, Dr. Amar.
Right. So again, I think very clearly defined. And I mean, in every image and in every slide, we are introducing some new concepts for you to take home. So 15 mm cutoff is important. The shape of the lesion is important. The representation of these lesions in the T2 weighted ADC and DWI sequences are important, and they have to be represented in each sequence in order to define as cancer. So this is another big tumor in the, Dr. Basit, please.
Again, we see, if we look at the anterior part of the prostate, we see again a hypointense, ill-defined area, which is T2 hypointense, and on ADC mapping again appearing markedly hypointense with diffusion restriction. So this lesion again is highly suspicious, and as we have discussed, the size of this lesion is 27 millimeter, making it a category 5 lesion. And again, on the images, the capsule looks to be intact, and the ill-defined appearance, hypointensity on T2 and ADC mapping is making it highly suspicious for prostate cancer. Yes, Dr. Amar.
Right. So we are moving forward now, and as you can see that this is another selected image. This is the bladder here, the prostate, and I think now what you see with what you have not seen in the previous lesions is the irregular shape of the whole gland. So Basit, why is it, where is the capsular breach, and why is it a locally advanced disease?
Yes, so if just by looking at these images, the moment you will see this image, you will be confused, where is the prostate gland? So we cannot see the peripheral zone, we cannot see the central, the transitional zone, we cannot make out the hypo-intense or the black line of the capsule, no hyper-intense signal of the peripheral zone that we otherwise expect. So this is this entire thing, as you have already shown, the white structure on the top of the image is the bladder, the part of the bladder that we can see. But if you see that posterior to the bladder, this whole area is hypo-intense. And if we follow the margins, especially on the left side, you see the lobulations. This is infiltration into the paraprostatic fat. And if we go on the right side of the screen, there is one bright structure, which is tubular kind. So this is part of the seminal vesicle that is seen. The seminal vesicle is also infiltrated, and just on the right side towards the midline, if we see this nodular appearance or lobulated appearance is also extending posteriorly into the mesorectal mesorectum as well. You can see this white or this fat, which is bright, is appearing fuzzy here. So this whole prostate gland is the visualized portion of the prostate gland on this section is entirely replaced by abnormal signals, which with this lobulated indistinct appearance. This is highly a locally advanced lesion, which is infiltrating the paraprostatic fat, extension beyond the capsule, infiltrating the seminal vesicle and extending into the mesorectum as well. And I think this is
a video.
Yes. So again, if we see this video, this is moving inferiorly, and you can see this on the right side of the screen shown by this yellow. This is an infiltrative tumor which is infiltrating the anterior wall of the rectum as well as the pelvic side wall shown by this arrow. and the mesorectum as well. And if we see that this is very ugly appearing, and if we see along on the left side, there are multiple internal iliac lymph nodes as well. You see the appearance of these lymph nodes is also similar to the appearance of the primary tumor on these T2 weighted images. So there is extensive lymphadenopathy and this is kind of a T2 lesion if we see the TNM classification. And of course, that will be explained to you by Dr. Hamad, I hope. And this ugly looking lobulated lesions is locally infiltrating with nodal metastasis on this video. Yes, Dr. Hamad.
Yes, thank you. Yes, I mean, it is showing a large lymph node. It is going up to the pelvic side walls. It is infiltrating the Denonvillers fascia into the mesorectum, and loss of fat plane between it and the rectum. So this is a locally advanced prostate cancer with lymphadenopathy. And if we look in the other sequences in the T1 weighted post-contrast and pre-contrast images, we find that there are lymph nodes which are not loco-regional but distant. So that has made it as a metastatic prostate cancer. So you see how by following certain very basic rules, you can really understand the anatomy on MRI, something that myself included were really afraid in looking at the MRI scans, because we won't be able to understand. But now you can see the anatomy so well and understand the anatomy. You can see the capsule of the prostate here, whereas on the left side, it is a big extension into, and as Dr. Basit explained, going all the way into the mesorectum, up to the anterior rectal wall. It is going into the pelvic side wall. There is large lymph nodes as well, which has very similar intensity as Dr. Basit explained with the primary cancer. So I think it's quite clear even to urology residents, trainees, and myself that this is a locally advanced prostate cancer. I think this is all something that we have seen. The biopsy showed ISUP 4 lesion with 5+4 Gleason score, and about 90% of the tumor was. Now, Dr. Basit is going to explain another important characteristic that we need to see a surgeon, and that is about the seminal vesicle invasion. So, Basit, over to you.
Yes, thank you, Dr. Ahmad. So this is selected sections from another case showing local extension. And if we see this yellow arrow is showing a tumor which is extending beyond the prostate. And if we see the seminal, if you can make out the seminal vesicles, the tubular structures that are slightly lateral to what is appearing hypointense or towards dark gray or blacker shade. So this hypointense signal of seminal vesicles on both the sides, the right and the left, seem to be lost along their medial aspect. And if we see that the disease burden is more on the left side, so this infiltration, this is suggesting infiltration into the seminal vesicle of the prostatic lesion, which on ADC mapping is again showing low signal or hypointensity with areas of marked hypointensity within it. So this is another example of local extension of the prostate cancer into the seminal vesicles. Yes, Dr.
So, yes, thank you. So this is important because I think I remember at least one case, and this is some years back, where a poor quality MRI scan, the seminal vesicle invasion was missed. We end up doing attempting a radical prostatectomy, and it was extremely badly adherent, and it was really a nightmare surgery. You realize seminal vesicle invasion once you have dissected the prostate off from the apex, and you are doing posterior dissection once you have cleared it off from the adenovillous fascia. When you are moving up anteriorly, you find that the seminal vesicles are invaded and they are badly adherent laterally and posteriorly into the bladder. That makes surgery a real bad experience. So all these things are important to realize before surgery, and that provides you the roadmap for making a decision about surgical intervention in these patients. So seminal vesicles, as you can see here, this is the location of the seminal vesicles, the ejaculatory duct and the ductus deferens, prostate location here. And once you have dissected this off and you are going behind the prostate to release it posteriorly from the recto-urethralis fascia, it's only then that you realize the seminal vesicles show local involvement and make lives very difficult for you. So the end staging is the next stop and the next point that we are going to discuss. Dr. Basit will explain further, but DWI and T1 weighted series are important in making the decision about nodal disease. And as I've said, that when you're doing an acquisition, you need to have T1 weighted image, preferably with contrast before and during and after administration, to see from the bifurcation of aorta down up to the urethra, to identify all the lymph nodes in the external iliac, internal iliac, obturator, common iliac, and up to the bifurcation of aorta, that point, and then obviously the lymph nodes in the mesorectum. And all these are important. What makes a lymph node suspicious is that if it has a round shape, and this is something that we do discuss regularly in the tumor board meeting, a round shape and a short axis of greater than 8 millimeter, an oval shape with a short axis of greater than 10 millimeter, the heterogeneous appearance, and the irregular margins. So all these are extremely suspicious characteristics. So when you identify a lymph node, the things that you need to see, that if it is round shape and it has a short axis of greater than 8 millimeters, it is likely to be malignant. And if it is oval shaped and the short axis is greater than 10 millimeters. So any other points, Basit, about the nodal disease?
Yeah, absolutely. I totally agree. Sometimes these ADC mapping with complement from the diffusion suggest, but we need to consider the limitation of MRI for accurately defining the lymph nodal involvement, especially if it comes to the size. So for that reason, lymph nodes which have an oval shape have a slightly different criteria, which is 10 millimeter or more, versus totally round lymph nodes for which the criteria is 8 millimeter or greater than 8 millimeter. So this and the heterogeneous appearance or restriction in the lymph node makes them suspicious for possible metastasis. Yes, Dr.
Right.
Amar.
Yeah. So this is the map of all the regional lymph nodes, which are pelvic, hypogastric, median sacral, internal and external iliac. The distant lymph nodes are the one on the aortic lymph node, the common iliac, inguinal, and supraclavicular. This makes it a metastatic disease. So when you are staging, this will be M stage. So if you have an aortic lymph node, this is not a regional lymph node, and this involvement is will be characterized as a metastatic disease. Whereas all these lymph nodes are basically your the green colored lymph node will be categorized as N0, N1, N2, and this will be all the red nodes are all your metastatic lymph nodes. Okay, so this is important that if you see lymph nodes in this location which are suspicious, you will categorize as an N lesion, and this you will categorize as a M lesion. So this is showing the lymphadenectomy. This is the internal iliac artery. This is the external iliac artery. This is the bifurcation of common iliac, what is called the angle of Marcial. And this is the vein, the external iliac vein here, obturator fossa with an obturator nerve here. So all lymphatics belonging to the internal iliac, external iliac, up to the genitofemoral nerve laterally is that you resect. And you also go medially to search for median sacral lymph nodes. And these lymph nodes are all important to do the local staging of disease. The current EAU guidelines, this is obturator fossa. You can see the obturator nerve here, and you have to remove lymphatic from the obturator fossa, which is the most important area where lymphatics would go as a first thing, but there is no set pattern to it. So if you do decide to do lymphadenectomy based upon your nomograms and pre-surgery criteria, you do extended lymphadenectomy, which means that you go up to the bifurcation of the aorta. Okay, so some words, Basit, about the BPH and the transition zone and the BPH nodules.
Yes. So one thing which most of the radiologists find challenging is differentiating changes of BPH versus lesion, of course, in the transitional zone. So for identifying BPH, we usually see changes of BPH, of course, in the transitional zone. And if we look at the image, which is on the tops of the screen, there are these marked circle areas are areas of hypointense or mixed signal intensity. They are usually encapsulated and are very well defined versus lesions which are not encapsulated and not well defined. They will behave, they will have similar appearance, like they are also hypointense on T2 and on ADC as well. But on diffusion, they will not be showing hyperintensity. Sometimes mixed signal intensity can be seen, but their appearance, which is well-defined encapsulated lesion, are usually changes of benign prostatic hyperplasia. And because these changes are seen in the transitional zone, and they also show enhancement similar to what we see for lesions in the peripheral zone. That is the reason contrast enhanced MR images are not primarily seen for evaluation of the transition zone. So whenever we see encapsulated well-defined lesions, which have a similar appearance on T2 and ADC, so they are less suspicious for malignancy, versus ill-defined lesions without or uncircumscribed margins with diffusion restriction are suspicious lesions. And we can compare these well-defined lesions versus a lesion which is seen on the left side at the peripheral zone. If we see the margins of these lesions are very ill-defined, uncircumscribed. And again, if we follow them on the ADC and diffusion, this is showing significant signal changes, making it highly suspicious versus the changes that are of benign prostatic hyperplasia in the transitional zone. Yes, Dr. Mohan.
Yes, so thank you very much. I think the same point that Dr. Basit explained earlier on as well. This is the surgical capsule. These are the so-called BPH nodules. And if you look at here, this is a highly suspicious area, and it is clearly represented favorably on ADC and DWI. So in all these sequences, it is represented, and it is a highly suspicious lesion, and it is categorized as Pirate 5. Another example of the BPH nodule here.
Yes, sometimes,
Yes,
Dr. Amal, and sometimes you can also see hyperintense signals on T2 weighted images within the benign prostatic hyperplasia changes. So either they can be hypointense or hyperintense like this. The hyperintensities are suggesting cystic changes within them. So, but remember, if they are encapsulated, well circumscribed, these appearances make them less suspicious versus ill-defined or uncircumscribed appearance, which is usually for cancer. Yes, sir.
okay, thank you. So yeah, please go carry on. Gigi, please.
Okay, so these are the differences between the prostatitis changes versus prostate cancer. Usually they are well defined, either they can be band-like or like a wedge shape, well circumscribed lesion versus round or droplet shaped kind of appearance for prostate cancer. They have sharp borders when it is changes of prostatitis versus ill-defined borders of the prostate cancer. And on ADC, the cancer is markedly hypointense. That means more towards blacker shade versus on prostatitis, it is hypointense, but it is very less high in terms of hypointensity. DWI is usually normal in prostatitis versus in cancer, where it will be hyper intense or very bright appearing. Dynamic enhancement is seen in both of these. For that reason, you cannot distinguish prostatitis changes on contrast enhance, because BPH changes can also enhance early like the cancer. Yes, doctor.
Thanks.
So this is again, yes,
please
you
carry
can
on.
continue.
No, that's fine.
So this is just summarizing the prostatitis and benign features like fibrosis, scarring, and atrophy, or post-biopsy hemorrhages. They can sometimes mimic cancer, especially in the peripheral zone, and we need to follow the rule. Their appearance, their margins or borders, whether ill-defined or well-defined. If they have a particular wedge shape or a band-like appearance, then they are mostly benign versus rounded or droplet-like. And then we have to see the appearance on ADC, whether it is markedly hypointense or just subtle hypointensity, and showing diffusion restriction. So these are the changes which directs us towards thinking for cancer versus these hyperintensity, encapsulated appearance, well-defined margins, No changes on DWI sequence, just mild hypointensity on ADC. Their location in the central zone or the peripheral zone, of course, but the appearance of bed shape or band-like, and no changes on DWI. So these are likely to be inflammatory changes versus the one we discussed for the cancer.
I think this is extremely important because the appearance on rectal examination may be suspicious. You may have a raised PSA, which is one of your surrogate marker for ordering a biopsy. So in all these situations, if you do an MRI scan, and an MRI scan will help you in making a decision whether this patient would benefit from biopsy. And we know that biopsy is not a benign procedure and it has significant morbidity, even death as well. So we need to make those decisions prudently by looking at the good quality MRI scan and discussing it with a radiologist who understands and read prostate MRI well. And you can avoid unnecessary biopsy in these situations. And as Basit explained, there are very clear features which separates cancer from prostatitis.
So again, this is a slide which will help the audience better understand the two things, which is of course prostatitis versus the cancer. So the images that you see, if you see the lesion which is shown by the arrow, the yellow arrow, so you can see on T2 it is slightly hypointense, on an ADC it is also slightly hypointense, but on DWI it is barely kind of appreciable. So these findings, and if you again look at the T2, the margins of these lesions are well defined or sharp. You can see this is making a wedge shape kind of appearance. And this kind of, if you see this kind of thing, then we call this more like a prostatitis kind of changes versus those of the lesion. And can we show the other images so that we compare the two? So if now you see the images which are shown by these on the contralateral side on the right, on the left side, you see this orange arrow. You see a hypointense lesion. Compare the hypointensity of the two lesions. This is more hypointense with the fuzzy or ill-defined margins, and subsequently on ADC it is markedly hypointense, and on DWI this is definitely bright. So this is highly suspicious for a cancerous lesion versus the changes of prostatitis, which are subtle if versus the changes of prostate cancer, which have typical features.
So again, very important point that Basit has been making all evening today, that you have a lesion identified on T2 weighted image. There are certain characteristics of this lesion which, beg your pardon, which separate it from the cancer versus prostatitis. It is represented here as well, but nothing here. Similarly, in the cancer, you have to have this hypointense lesion, very hypointense lesion on ADC, and a hypointense lesion on a bright lesion on the DWI images. And this would make it a cancer based upon size, configuration, prostatic extracapsular extension, etc. The characteristic, you will call it 4 or 5 and category, and then obviously order biopsy for this set and not for this set. although the PSA values may be the same for both of these patients. But obviously one has cancer, the other one doesn't.
So the next slide again, we see that we see lesions which are seen at the peripheral zone bilaterally. They are slightly hypointense but well defined with sharp margins, kind of wedge shape, and they are kind of symmetrical if you see. And on subsequent ADC, they are again appearing slightly hypointense, but not very, very hypointense. And on DWI, the appearance is not very bright. So this is again a lesion which is in the favor of benign changes like prostatitis. Bilateral, symmetrical, and sharp defined margins with less hypointensity and no restriction. So this is prostatitis changes. Yes, Dr.
Yeah.
So again, the next case in this, you can see that the peripheral zone hyperintensity or the bright signals is lost, but it is symmetrical. We can make out that this again is sharp, and we do know on corresponding ADC, we do not see that there is any hypointensity in it. On DWI, it is slightly bright, but we have to respect the ADC. On ADC, it is not behaving like on T2. So this is again an example of benign changes of chronic prostatitis, in which sometimes T2 image will show, but remember this has to complement with ADC to make it a cancer on which it has to be very, very hypointense. If it is subtle hypointense or no hypointensity, then it is less likely to be cancerous lesion. Yes, Dr.
So some
And
examples of the negative biopsies.
yes, you
And I
want
think,
to say?
I think we have discussed all those points which can make it a negative biopsy. And I think you have very clearly mentioned that what are the characteristics of a BPH nodule versus tumors in the peripheral zone and the prostatitis, which can be a real confusion in clinical scenarios. So I think these things must be very clear to our audience that you need to, in all cases where you have suspicion that the patient may have prostatitis, clinically, you do an MRI scan and you can avoid a unnecessary biopsy. So with this, we conclude today's conceptual based course. And I hope that the 2 sessions over the last 2 hours that we have spent, you probably may have some clarity. I have learned a lot in these sessions from Dr. Basit and Shayan. And if you want to look at in greater depth, I have provided 3 resources which I have used to prepare this presentation, the 2 articles from European Urology. And this is the website that I have used Radiology Assistant to get some of the images and cases, which are very textbook cases to illustrate the point. So with this, thank you very much, Basit, for your very informative and very lucid talk and clarifying some of the confusion in the mind of most of the urologists, and hope to avail from your expertise in future as well. So
Thank you so much.
Thank you, and good evening, and we'll see you in the next conceptual based course. There are something in the chat box. So, okay, so this is Dr. Nazim is thanking Basit Salam, myself and Dr. Shayans, and Ahmed Bashir is thanking Dr. Basit. So thank you very much and have a very good evening.
Thank you so much.